Okay, let's unpack this. We are doing a deep dive today into a topic that is, it's really the foundation of general surgery. We're talking about the presentation, the diagnosis, and of course, the surgical management of inguinal swelling. If you are prepping for a surgical exam or you're a med student just hitting the wards or, just someone who wants that level of precision in these high-stakes scenarios, this is for you.
Precisely. And we're not just scratching the surface here. We're pulling from advanced surgical exam-ready source material. This is the kind of stuff residents need to know cold for their boards. So the goal is for you to understand not just what it is, but why the anatomy drives everything and how we actually fix it today.
And you really have to appreciate the scale of this. Hernia repair is one of the most common operations in the world, millions every year. But for that one surgeon with that one patient who has a bulge in their groin, it's potentially life or death.
And that danger immediately sets our mission. The absolute overriding question when you see that patient is this a hernia? And right after that, so what kind is it and can I push it back in?
And that's really about the ultimate triage, isn't it?
Absolutely. We are immediately on the lookout for the two worst-case scenarios. Is it obstructed or is it strangulated? If there are any signs of strangulation, ischemia, infection, the clock is ticking. Life comes before limb. The diagnosis has to be fast, and it has to guide you straight to the OR. But before we can even think about fixing it, we have to master the geography.
What's fascinating here is, the high recurrence rates, the chronic pain that really plagued hernias of surgery for decades. It was almost all because of let's say, a lack of respect for the really intricate, layered anatomy down there. A successful repair is 100% dependent on knowing where you are.
Okay, so let's start with the GPS of the groin. The fixed points you can count on, even if the patient's anatomy is challenging.
Right. You always rely on two fixed, palpable points. Laterally, you find that bony bump on your hip. That's the anterior superior iliac spine, or ASIS. Then medially, you find the pubic tubercle, the PT. Those 2 points define the course of the inguinal ligament.
Also called Poupart's ligament, right? Exactly. It's really just the thickened, rolled up bottom edge of the external oblique aponeurosis.
And why is knowing the midpoint of that ligament so critical for a surgeon?
Because that midpoint is your landmark. Just about there, maybe a little above and lateral, is the rough location of the deep inguinal ring.
Well,
that's the entry point for the most common type of hernia, the indirect one. If you miss that landmark, your whole dissection starts off on the wrong foot.
Okay, before we dive into the canal itself, let's do a quick run-through of the 9 layers of the abdominal wall.
Yeah.
It's a classic exam question. You have to know it.
You do. So from the outside in, you've got skin. Then the 2 layers of superficial fascia. There's Camper's fascia, which is the fatty layer, and then Scarpa's fascia, which is more membranous. Under that, you hit the 3 muscle layers, or their aponeuroses. External oblique, then internal oblique, then the deepest one, transversus abdominis. Then, and this is the crucial one, you hit the transversalis fascia. Deep to that, there's some extraperitoneal fat, and then finally the peritoneum, which is lining the whole cavity.
I want to pause on those fascial layers for a second. Camper's and Scarpa's. They seem simple, but isn't the space between them why you see things like seromas after surgery?
That's exactly right. Scarpa's is a pretty firm layer. If you're a bit too aggressive with your dissection, you can create dead space there. And if fluid lymph or blood collects in that space, boom, you have a seroma or a hematoma. Understanding those planes helps you minimize that risk.
And if we had to pick just one layer, the single most important layer in hernia pathology, where all the weakness for a direct hernia comes from, it has to be the transversalis fascia.
100%. The transversalis fascia is the true engineering bedrock of that posterior wall. It's a thin sheet, sure, but it's the last real barrier before you hit the fat outside the peritoneum. When that life gets weak or stretches out from age or pressure, things push straight through. That is the definition of a direct hernia. Our entire goal with the modern mesh repair is just to reinforce that specific layer.
So now let's define the canal itself, the inguinal canal. It's short, maybe 4 centimeters, in an adult. What's actually traveling through that tunnel?
In men, the main thing is the spermatic cord. In women, it's the round ligament of the uterus. But the other contents are just as important surgically because they're the source of so much trouble later. We're talking about nerves, specifically the ilioinguinal nerve and the genital branch of the genitofemoral nerve.
Right, the source of chronic pain. To visualize the canal, surgeons often use the box analogy. Can you walk us through the 4 boundaries?
Sure, let's define the box. The roof is formed by the arching fibers of the internal oblique and transversus abdominis muscles. The floor is just the inguinal ligament. The anterior wall, the front, is mainly the tough external oblique aponeurosis. And the posterior wall, that's our all-important transversalis fascia. Medially, it gets a little help from the conjoint tendon.
It seems a bit counterintuitive that the front wall is supposedly stronger. Why do direct hernias, which are a weakness in the back wall, happen so much more in older adults?
That's a great question. It's because that anterior wall, the external oblique, is made of really dense, tough collagen fibers. It's like a sheet of canvas. The posterior wall, the transversalis fascia, is much thinner. It's more like a bed sheet.
Oh.
And while the muscles in the roof are supposed to contract and protect it, if they get weak with age, or the fascia itself just degenerates, the pressure finds the path of least resistance. And that's straight through the back wall, through Hesselbach's triangle.
Okay, let's talk about the rings, the entry and exit points. The deep inguinal ring.
The deep ring is basically a hole in the transversalis fascia. It's where the spermatic cord officially leaves the abdominal cavity. An indirect hernia sac pokes through that hole, so it travels right alongside the cord structures. And this is the key anatomical relationship. That ring, and therefore the indirect hernia sac, lies lateral to the inferior epigastric vessels. That is the single most important landmark.
And the superficial ring is just the exit.
It's just the exit. It's a little triangular split in the external oblique aponeurosis right above the pubic tubercle. It's the point where the hernia and the cord become subcutaneous, where you can actually feel them under the skin.
Okay, this brings us to that critical piece of geometry, Hesselbach's triangle. For anyone listening, these borders are non-negotiable. You have to know them.
You absolutely have to. So the triangle is formed by three things. Medially, you have the lateral edge of the rectus muscle sheath. Laterally, you have the inferior epigastric vessels, and the base, the inferior border, is the inguinal ligament.
So that moment in the OR when you've opened the canal and you see the vessels, that's the diagnostic moment. Your relationship to those vessels tells you everything.
It tells you everything. If the bulge is coming through medial to those vessels, it's a direct hernia. It's a failure of the posterior wall inside that triangle. If the sac is coming out lateral to the vessels through the deep ring, it's an indirect hernia. That vascular landmark is the key.
Okay, one last piece of anatomy before we move on, and it's the one that causes the most trouble. The femoral canal.
Right. The femoral canal is a completely separate space that lies below the inguinal ligament, and its boundaries are rigid. You've got the femoral vein right next to it, and this tough little ligament medially called the lacunar ligament.
And why does that location make a femoral hernia so much more dangerous?
Because the walls are made of bone and tough ligament, the entrance, the femoral ring, is narrow and it doesn't give. So if a piece of bowel or fat pops into that tight space, it gets squeezed immediately. The pressure cuts off the blood supply and that leads to strangulation. Fast. That's why any femoral hernia is considered a surgical priority, no matter how small it seems.
Okay, so moving from the walls of the canal to what's inside it, the spermatic cord. We talk about it like it's one thing, but the surgeon has to dissect it. What are the critical structures inside?
Yeah, you have to be so careful here. If you think of the classic vein, artery, nerve in the cord, you're looking for the pampiniform plexus of veins, which is a whole network of them, the testicular artery, and the vas deferens. The vas is usually posterior and medial, and you can feel it. It's firm, like a piece of cooked spaghetti.
I've heard it called a reversed van sometimes. Is that relationship always consistent?
It's a good general guide. The vase is your most reliable landmark because of its texture. The testicular artery runs very close to it. The pampiniform plexus of veins is usually the largest component, more anterior and lateral.
And the big warning about the testicular artery.
You just can't compromise it. It comes all the way down from the aorta, and if you pull too hard on the cord while you're dissecting a hernia sac, you can cause it to spasm or even tear it. If you ligate that vessel, you risk testicular atrophy. The testicle can just die. So you have to be incredibly gentle.
Now let's talk about the silent enemy you mentioned earlier, the nerves. The source material has that great line, know your rings and your nerves. Chronic pain comes from nerve ignorance.
This is what can turn a successful surgery into a disaster for the patient's quality of life. We're talking about post-herniorrhaphy neuralgia, pain that lasts more than 3 months. It can affect up to 10% of patients, and it's almost always from injuring one of these tiny little sensory nerves.
And which nerve is the main culprit, especially in open repairs?
Hands down, it's the ilioinguinal nerve. It supplies sensation to the inner thigh and the scrotum or labia. And its path is it's right in the line of fire. It often lies right on top of this spermatic cord. It's so easy to accidentally catch it in a suture or crush it with a clamp or just cut it if you're not actively looking for it.
So how do you actually avoid injuring it during a Liechtenstein repair?
First, you have to find it early. It looks like a little piece of white thread. Once you find it, you gently mobilize it and retract it out of the way. Then, when you're placing your mesh and sutures, you have to be absolutely sure you're not putting a stitch anywhere near it. Because even if you don't hit it directly, the scar tissue or the mesh shrinking can trap it later, and that causes a terrible entrapment neuropathy.
And what about the other nerves, the iliohypogastric and genitofemoral?
The iliohypogastric runs a little higher up, so it's less commonly injured. The genital branch of the genitofemoral nerve is trickier because it runs inside the cord itself, so it's at risk during dissection of an indirect sac.
So the message is, a successful repair isn't just about closing the hole. It's about the patient being pain-free 6 months down the line.
That is the ultimate measure of success.
Mm-hmm.
Absolutely. Okay, so if we connect all this anatomy to the clinic, the next step is diagnosis. A patient comes in with a swelling, you have to run through your threat matrix. First, the big 3 hernias, then all the mimics.
Let's quickly define the big 3 again, focusing on how they present clinically.
Right. 1, indirect inguinal hernia. It comes through the deep ring, lateral to the vessels. It follows the path of the cord, so it often descends all the way into the scrotum. This is your classic scrotal hernia, and you see it a lot in younger people. 2, direct inguinal hernia. This is a weakness in the back wall, medial to the vessels. It pushes straight out. Clinically, it's usually a broad, sort of hemispherical bulge that almost never goes into the scrotum. This is the hernia of an older guy with a chronic cough. And 3, femoral hernia. Below the inguinal ligament, it presents lower down. And again, we just can't stress this enough. This one has a very high risk of strangulation.
That distinction is so key, the one that goes into the scrotum versus the broad bulge. Now, what about the traps? The things that look like a hernia, but aren't?
The absolute classic trap is the saphenous varix. It's a dilation of the great saphenous vein right where it joins the femoral vein. It pops up in exactly the same spot as a femoral hernia.
So if a patient has this soft, compressible lump, how do you know it's a varix and not a hernia?
It's all about the disappearing act. A varix is soft, it might have a bluish tint, and you'll feel a cough impulse. But here's the key. When the patient lies down flat, the venous pressure drops, and the varix completely vanishes. A reducible hernia might flatten out, but you can usually still feel the defect. The varix is just gone.
What about swollen lymph nodes? That's another common one.
Lymphadenopathy is a lump in the groin, not a hole through the groin. If the nodes are tender, you're thinking infection, a cut on the leg or an STD. If they're hard, fixed, and non-tender, your mind has to immediately go to malignancy.
Any other less common mimics to keep in mind?
For sure. You can get a lipoma of the cord, which is just a fatty tumor that feels like a hernia but isn't reducible. And very rarely, but very importantly, a femoral artery aneurysm. If you feel a pulsatile expanding mass below the inguinal ligament, do not push on it. That is a vascular emergency.
So once you're pretty sure it's a hernia, your history taking has to get really focused. What are the key questions you ask?
You're hunting for risk factors for increased abdominal pressure. Do you strain to have a bowel movement? Do you do a lot of heavy lifting? Do you have a smoker's cough that just won't quit? All of those point towards a direct hernia, a weakness from wear and tear. On the other hand, if you have a young, healthy person who's had a swelling that comes and goes since they were a kid, that's the classic story for an indirect hernia from a congenital defect.
Okay, let's hammer home the red flags one more time. The signs that mean you stop talking and start moving.
Severe, constant pain that's getting worse. That means tissue is dying. Vomiting and they can't pass gas or stool. That's a bowel obstruction. And finally, any systemic signs, fever, a high heart rate, tenderness that makes them jump, that's strangulation. You don't need a CT scan to tell you that patient needs to go to the operating room right now. The physical exam is really where you put all that anatomical knowledge to work. You have to look at the patient standing up when the hernia is most obvious, and then lying down to see if you can reduce it.
And the single most effective differentiator, like we said, is its relationship to the pubic tubercle. Let's walk through that again.
Okay. Patient is standing. You find their pubic tubercle. 1, if the swelling is above and lateral to the tubercle, and especially if it goes down into the scrotum, you're betting on an indirect hernia. 2, if it's a broad bulge that's above and medial to the tubercle and stays out of the scrotum, it's almost certainly direct. And 3, if the swelling is below and lateral to the tubercle, it's a femoral hernia, and your sense of urgency should go way up.
What about the cough impulse? Is that a reliable sign?
A cough impulse just tells you the swelling is connected to the abdomen. It confirms it's a hernia or a varix, but it doesn't tell you the type. But here's the important part. A strangulated hernia often loses its cough impulse. The contents are wedged in so tight they can't move. So a painful, irreducible lump with no cough impulse is a huge red flag.
There's also that old school bedside test, the deep ring occlusion test. How does that work?
It's a great little maneuver. With the patient lying down, you gently push the hernia back in. Then you take your thumb and press firmly over where you think the deep ring is, about midway along the inguinal ligament. Then you have the patient stand up or cough.
And the results.
If the hernia stays in while you're pressing, it means you've blocked its exit from the deep ring. It's an indirect hernia. But if the hernia pops out medial to your thumb while you're still pressing, it means it's coming straight through the back wall. It's a direct hernia. A very neat trick.
Once you have the type, you classify the urgency. This is so critical.
Right. There are 3 categories. Reducible. You can push it back in. That's an elective repair. We can take our time, optimize the patient. Incarcerated or irreducible. It's stuck. It's not dead yet, but it's trapped. This needs urgent surgery within hours before it strangulates. And strangulated, the tissue is ischemic, it's dying. This is a life-threatening emergency. The patient goes directly to the OR, no delay.
Is there ever a time you just watch a hernia and not fix it?
Yes, actually. The idea of watchful waiting is an option, but only for a very specific group. Elderly men with asymptomatic reducible inguinal hernias. For them, the risk of strangulation is pretty low, and the risk of chronic pain after surgery might be greater than the benefit of the repair. But this absolutely, under no circumstances, applies to femoral hernias. All femoral hernias get fixed. Okay, so now we shift to the OR, the technical side of things. And for a trainee, this is all about understanding the decision points. Open versus laparoscopic, and the classic tissue versus mesh debate.
Let's start with prep. Since we're usually putting in mesh, a foreign body, the pre-op steps must be perfect.
It's all about infection prevention. A dose of 5e antibiotics, usually cefazolin, has to be in the patient within an hour of the first cut. That is non-negotiable for a mesh repair. We also really push for smoking cessation. Nicotine just kills wound healing and increases the risk of recurrence.
And the consent form has to be detailed, covering all the potential bad outcomes.
Absolutely. You have to explicitly mention the risk of chronic pain, the risk of recurrence, and in an emergency, the possibility of bowel resection or even orchiectomy, losing the testicle, if things are really bad.
All right, let's get to the gold standard of open repair. The Lichtenstein repair. What made it so revolutionary?
It's all about one concept, tension-free. Before Lichtenstein, most repairs involved sewing weakened tissues together under tension. And not surprisingly, the stitches would often pull through and the hernia would come right back. Lichtenstein's idea was to stop pulling things together and just patch the hole. Lay a synthetic mesh over the weak area with no tension at all.
Can you walk us through the key steps of a Lichtenstein, focusing on the critical maneuvers?
Sure. You make an incision parallel to the inguinal ligament. You open the external oblique aponeurosis to get into the canal. As you do that, you have to be looking for that ilioinguinal nerve. It's right there. You then find the spermatic cord and loop it with a little tape to lift it out of the way so you can see the floor of the canal.
And then you identify the hernia type.
Right. If it's direct, you'll see a diffuse bulge in the floor. If it's indirect, you'll see a distinct sac coming out of the deep ring. And how you handle that sac is different. For a direct hernia, you just push the bulge back in. The mesh is what does the real work. For an indirect sap, you have to carefully dissect it away from the cord, open it to make sure it's empty, and then tie it off high up at the deep ring.
Now wait, I've seen surgeons leave the distal part of a long indirect sac behind. Why not take the whole thing out?
That's a great surgical pearl. If that sac goes way down into the scrotum, it becomes incredibly stuck to the vas and the testicular vessels. Trying to dissect that whole thing out puts those structures at a huge risk of injury. So you do a high ligation at the neck, which closes it off from the abdomen, and you can safely leave the disconnected distal part behind. It minimizes risk.
Okay, sac is handled. Now the mesh, how is it placed and secured?
We take a piece of polypropylene mesh, cut a little keyhole in it for the spermatic cord to pass through, and lay it over the entire floor. We use very few stitches, 1 or 2 to anchor it to the pubic tubercle and the inguinal ligament. The goal is for it to lie flat, with no tension.
And the main goal of that mesh is to cover what exactly?
It has to cover the entire myopectoneal orifice. That's the whole weak area that includes the deep ring, Hasselbalch's triangle, and the femoral canal. If you cover that whole area, you prevent not just a recurrence of the inguinal hernia, but also a future femoral hernia.
Before mesh, The big name was the Schodus repair. Why did people still talk about it, and when would you use it today?
The Schodus is a work of art. It's a meticulous 4-layer reconstruction of the posterior wall using only the patient's own tissue. In the hands of surgeons who do it all the time, the recurrence rates are as good as mesh. We still use it today when mesh is a bad idea, like in a contaminated field or sometimes in very young athletes.
And the McVeigh or Cooper's ligament repair.
That's a specific tissue repair where you suture the conjoint tendon down to Cooper's ligament on the pubic bone. It's a very strong repair that's particularly good for fixing femoral hernias or very large direct defects.
Okay, let's shift to the modern approach. Laparoscopic repair, TAPP and T-TEPI. This is a totally different philosophy.
It really is. Instead of repairing from the outside in, you're working from the inside out. You place a huge piece of mesh in the preperitoneal space behind the muscles. The beauty of it is that you're using the patient's own intra-abdominal pressure to push the mesh up against the defect, holding it in place. The advantages are typically less pain and a much faster recovery.
Can you break down the difference between TAPP and TEP?
Sure. TAPP stands for transabdominal preperitoneal. You go into the abdomen, just like for a gallbladder surgery. Then you cut the peritoneum from the inside, place your mesh, and sew the peritoneum shut over it. The downside is you're inside the belly with all the risks that entails. TAP is totally extraperitoneal. This is harder. You create a space between the peritoneum and the muscles without ever entering the abdominal cavity. You work entirely in that potential space.
So why would anyone do the harder TT approach?
Because it avoids all the risks of being inside the abdomen, no risk of injuring the bowel or causing adhesions. It's often preferred for bilateral hernias or for patients who've had a lot of previous abdominal surgery.
So when you're deciding between open and laparoscopic, what's the thought process?
If a patient has a hernia that came back after a previous open repair, you'd want to do the next one laparoscopically to avoid all that scar tissue, and vice versa. If they have hernias on both sides, laparoscopy is really efficient. But if it's an emergency, especially a strangulated hernia, you're almost always going to do an open repair.
Okay, let's drill down on that emergency scenario. The strangulated hernia, you open the sac. What's the immediate priority?
Bowel viability. That is the only thing that matters in that moment. You release the tight band of tissue that's constricting the bowel, and then you watch.
What are you watching for? How do you know if the bowel's going to live?
4 things. Color. It should go from a scary dark purple back to a healthy pink. Peristalsis, you should see it start to wiggle again. Arterial pulsation in its blood supply. And if you prick it, it should bleed. If after a few minutes of warming it up, it still looks dead, it has to come out.
And if you have to resect bowel, how does that change the repair?
It changes everything. The second you cut into the bowel, the field is contaminated. And this is the absolute rule. You cannot use mesh in a contaminated field. You have to switch gears immediately and do a tissue repair, like a Schuldeis. If you put mesh in there, you are guaranteeing a deep, nasty infection.
What about those really difficult femoral hernias? What are the specific surgical challenges there?
The femoral canal is just deep and tight. It's hard to see, and the femoral vein is right there, so you have to be so careful. There are a few ways to approach it, but for a strangulated one, you often use a high approach, like the McEvedy, which gives you access to the abdomen so you can assess the bowel properly before you try to pull it out.
Shifting gears to kids, pediatric hernias. The anatomy is the same, but the cause is different, which means the surgery is completely different.
Exactly. A kid's hernia is almost always a congenital indirect hernia. They were born with a little tube, the processus vaginalis, that was supposed to close but didn't. The key is that their muscles and fascia are perfectly strong. There's no acquired weakness.
So no mesh needed.
Absolutely.
Yeah.
And no MESH in children. The operation is simply a high ligation. You find the sac, tie it off at the deep ring, and that's it. The repair is done. It's a quick, straightforward operation.
Okay, finally the complication reality check. Let's talk more about the two big ones, recurrence and chronic pain.
Recurrence happens. Even with mesh, rates can be up to 5 or 10%. If a patient comes back after an open Lichtenstein repair, the best move is usually to go in laparoscopically for the second time around. You're working in a fresh, unscarred plane, and chronic groin pain. It's just the worst. It's the #1 cause of patient dissatisfaction. It can be a dull ache or a sharp burning pain. It's caused by trapping or injuring one of those nerves we talked about.
And if a patient has that and pain meds aren't working, what's the next step?
You can try nerve blocks with local anesthetic and steroids. If that fails, the only real option is surgery to cut the nerve and neurectomy. You trade their pain for permanent numbness in that area. It's a big decision, but for some people, it's worth it.
And after the surgery's all done, what's the key post-op advice?
We want them moving around early, but the most important thing is no heavy lifting. Nothing over 10 pounds for 4 to 6 weeks. You need to give that mesh time for the body scar tissue to grow into it and make the repair solid.
So what does this all mean? We've gone through a ton of anatomy, diagnostics, and technique. We need to boil it down into the most critical high-yield points.
Okay, let's do the must-knows, the things you have to remember. First, the anatomical line in the sand, the inferior epigastric vessels. Indirect is lateral, direct is medial. Second, the danger zone. The femoral hernia has the highest risk of strangulation. Always fix it. Third, the gold standard. The Liechtenstein repair is the benchmark for tension-free mesh repair. Fourth, the absolute rule. No mesh in a contaminated field, period. Use tissue. And finally, the chronic pain culprit, the ilioinguinal nerve. Find it, respect it, protect it.
And really, that concept of the myopectineal orifice, that whole weak area, is the master key. Whether you're doing an open or a laparoscopic repair, the goal is to cover that entire region to prevent any type of recurrence.
It's the groin's Achilles heel. If a hernia comes back, it's almost always because one of those spots on the orifice wasn't covered properly. Total coverage is the goal.
You know, we started this whole deep dive by talking about the power of physical examination. But the reality today is that for complex or recurrent hernias, surgeons are relying more and more on imaging like CT or MRI beforehand.
It's just practical. Imaging can tell you exactly what kind of hernia it is, where the old mesh is, if there's anything else going on. It helps you plan the perfect operation before you even make an incision.
So as we wrap this up, here's a final thought to chew on. The operating room is getting more and more high-tech. Better imaging, robotics, you name it.
Yeah.
So what are the long-term trade-offs between relying on this amazing technology for complex cases and the risk that we might lose that essential life-saving skill of just using our hands, of being able to palpate the anatomy and know exactly where we are, which is the very mastery we've been talking about today?
It's a real tension every surgeon has to navigate. How do you embrace the new tools without letting those foundational tactile skills erode?
Something to think about until our next deep dive.